ladies and gentlemen, this is the holy grail which is still we are in search for. Citicolin, the Ravans of the world are come, they are getting mad, they got some approvals, they are being used, but no, certainly it's no big neuroprotection. So at this point of time, when you had looked at the ischemic stroke, and initially when they said, okay, these are the patients you can thrombolize, you had a long list which actually meant you can't thrombolize. So people have looked out of the box. This was all based on some kind of, the biggest fear you have in IV thrombolysis, I may produce bleed in the brain, and there would be a problem. So it's a fear complex which actually made the initial guidelines so very strict that you didn't want anything happen to anybody, so you had a very, very small percentage who can actually come into that window period. So none really did, especially in a developing world. So currently the only exclusion is obviously no bleed. That's a no-brainer, isn't it? You're not going to give thrombolytic in a patient who has a bleed in the brain. And the previous history of ICH is also being looked into, but at least in the first 3 months you don't. The blood pressure has to be under control. The one parameter you take care, you will have a successful outcome. Blood pressure, number 1 cause of stroke, number 2 cause of stroke, number 3 cause of stroke. Even in a liver disease, you have a coagulopathy, it is the BP which is actually going to dictate a lot, both hyper and hypo, both are bad. It will cause a stroke, it will cause a stroke recurrence, it will cause a bleed after you intervene, it's a bad prognostic factor, plus it also causes dementia. So having your blood pressure stable and nothing actively bleeding anywhere, everything else in red have essentially been taken off. You don't need your PT-INR generally, but in a chronic liver disease you will. So whenever there is a system which is impacting your coagulation, you will need. But otherwise you have a 65-year-old, he is now in say an executive in some busy company. He is a hypertensive but well controlled, and he is in a meeting and he suddenly has slurring of speech and not moving the right side. Will you want to do PT, INR, platelets, etc.? You don't need to. So now the guidelines say you don't need to do that. So the global guidelines don't say, in fact, we were the first ones to point it out, and that came from a developing country when we published our data of 2007, and we had a huge backlash. How can you be away from, against a guideline, international guideline? I said, well, theek hai, aapki guideline aapka hai, this is my country and we have our own limitations. If I keep sticking to international guidelines, how am I going to forward with my national, our own objectives? So anyway, now the whole world accepts that. So, but then from 3 hours, it has now gone up to 4.5 hours that you can, there's a lot of literature which came in, level 1, that you can still IV thrombolize up till 4.5 hours, but that 4.5 hours is for the patients to come in, not for us. If somebody is come into our emergency at 2 hours after stroke, you can't say, oh, I still have 2.5 hours to thrombolize. Your door to CT time, your door to needle time is not even 1 hour. In fact, the time limit that in the country that has been set up is 12 minutes, door to needle time. So you can do that if your machinery or the stroke chain wheels are well oiled and moving. So the 2 lytics we have are altiplase and tenecteplase. This is one of our publications. This was a time aware. Since 2 decades, the first IV thrombolysis came in altiplase. Lot has happened on the x-axis and a lot more on the low axis, in the the y-axis. The above is your lytics, here is your endovascular. So much. In fact, 2013 they said nothing can be done about a mechanical thrombectomy. Cardiologist keeps doing their primary angioplasties, you guys can't do anything. And now, in fact, we are getting into a primary angioplasty. At least for us, there is no clinical equipoise, it's a large artery, take the clot out. So the interventions which actually have proven so beneficial, that there has been sort of this kind of an encouragement, this kind of a feeling that, oh, I can make a difference. There was a famous editorial by Michael Hill. He's a strokeologist from Calgary in Canada. And this was some time back. He's written that editorial. The biggest high that you get is when a stroke victim is wheeled into the emergency and he walks out of the hospital. Isn't that, that is what we want. That the guy goes back and is a useful member integrated back into the society. not being alive and being disabled, become a burden to himself and others. We don't want that. So that is possible if you get the right, the treatment, right time to the right patient. That's again a precision medicine, where I get that is true for across the whole medical field. So, but the 4 interventions which actually have been able to contribute to this is, I put stroke unit right on top, because that is the most cost effective, totally neglected, because everybody thinks ye to pata hai, people will do it. Nobody will do it unless you have the team which is built in to be able to do that. And aspirin, because of, well, I really don't know whether that will make so much. IV thrombolysis, why I put that here is, this is not, I mean, right now the thrombolysis rate in India is less than 5%. Best of stroke centers is about 33 to 35%. Still, that's a large room for improvement. So, not every patient can be thrombolized. Not every patient would need an endovascular thrombectomy. But this is one thing which has changed the world looked at the policy making. So, when you are putting out boards, come early, pick up strokes, fast, be fast programs. If this is the way, then it is, you have that lovely, I've seen those paintings, sir. When I walked in, I came to the OPD block and I saw those, prize winning paintings there. Such lovely things. It's basically, you said one life, one liver, it is one life, one brain, isn't it? So the issue here is, again, the same thing, that for the policy makers to take stock of the situation. It's because of, sir, that we have, the NFLD back into the ambit of the national program for, non-communicable disease. Otherwise, though, I think liver was also pretty much neglected, sir. Till very recently, you brought it into the national program. Stroke was also so neglected that even stroke is a recent entry. It was always hypertension, diabetes and cardiovascular. So here, we actually told the ministry ki kuch kar sakte hai. Okay, when you bring in the patient, and it will be so surprising, till 2013 April, you really didn't have IV thrombolysis. And when we went and represented, yeah, IVTB to hai, and you have to change your guidelines. Initially they said, aisa kya hai aapke paas ki, like, MI, you can do this, do you have anything like that in stroke? And remember 1995, the IV thrombolysis alteplase was approved in the world market. So there are still countries in this world who are not aware, who would not get in. And most important, even if you get in, you need this policy making and thrust from above for it to be implemented accordingly, because you're not looking at just private, you're looking at a huge government sector which has to cater to a large section of population. So for that, this is the game changer. So this is what, when we go up and tell them, look, when you come in time, you can do this. If you have it on board, you will be able to deliver. Therefore, there is an impetus for person to come in time to you, and they know, okay, my artery is blocked, it can be unblocked. The same parallel to a heart attack. Hemicranectomy is an important thing. The neurosurgeons come in there. So when there is a large MCA infarct, it's almost like one half of the brain is all gone, is pushing the normal brain. You need to salvage it, and there the number needed to treat is huge. 2 patients, you do hemicranectomy, you salvage 1 death. It's big. Of course, disability part of it, we'll come to that a little later. So now the algorithm is big, that less than 4.5 hours, more than 4.5 hours, whether there is a large vessel occlusion present or not, whether there is a mismatch present or not, you have chemical thrombolysis, bridge or only thrombectomy, and a lot of it is depending upon picking up a salvageable tissue. But when you're looking at it, some bright guy would come up and say, fine, then if everything is dependent on salvageable tissue, what's the guarantee that within 1 hour, especially if the collaterals are bad, everything is dead? And then you go about doing your endovascular thrombectomy for what purpose? And that's one of the reasons of failed interventions. But then, if you go on trying to determine what is still viable, even when they're coming within the first 4.5 hours, you may be cutting into again a time window. So therefore, there are looking at this kind of the probability and a large percentage not being into this kind of an area where collaterals are so bad that in the first 1 hour they're going to have everything which is dead. The guidelines still say that you don't have to do this mismatch if you're coming within the first 4.5 hours. But this is a relevant question, and sometimes your failed interventions may be because of this. Endovascular is a game changer. I really don't want to get into this because there is absolutely no clinical equipoise here. You have a large vessel, basilar, vertebral, ICA, middle cerebral artery till M2 division. There is a block, unblock it. You have the guy, you have a lab, you are in time, don't even think twice about that. Because that's absolutely essential. Even when you have, and this is especially true when there is a coagulopathy. When you can't give your IV lytics. You do this because here, even if your PTNR is high, even if the patient is on the coagulation profile, you can still do it. So this is one salvageable technique, but you will need to have the critical corpus of guys who can do it, and the wherewithals to be able to do. You'll have to have your lab there, you have everything functioning, and do it in time. So this is how you pull out a clot, whether it is, this is a stent reaver. So now they actually have either they pull out or they suck it out. So the sucking mechanisms is called penumbra. Solitaire is the, there's another trevo, solitaire, there's a mechanisms of, it's a mesh and they pull it out. And you combine sometimes and do this called solumbra. So there are these interventionalists. Now I think what been the advances, one, the corpus of those guys who can do it, thanks to our NEET FNB programs. And in fact, sir, I changed the DM curriculum for neurology in 23. It's on the website of NMC. I don't know how much is getting implemented. We said all DM neurologists should perform 10 CATs before they get the aborted, but NMC doesn't include AIMS and other INIs. And there's a big turf war. I told you there's a big bucks. So people who don't want other specialties to come up, but there's a NEET and FNB program now. So we have neurologists, we have neuroradiology, we have radiology, and we have neurosurgeons who can get into this program and are able to do it. And there's a large percentage of being done in south of India and the western part of India. North it is still less. Delhi has good number, but if you go to beyond Delhi, it's going to be a problem. Now I'm not talking of Gurgaon or Noida. Beyond that, in Uttar Pradesh, in Bihar, in Madhya Pradesh, in the east, in the north, nothing happening. So we have states where we don't have EVTs. So this corpus would be essential because again, time is brain. You will not be able to transport from one state to the other in time to be able to get these things. But these techniques are all there and they are absolutely available. They're all over the place in India. So in 2008, if we had this whole thing very scant as to what you can do, 2021 it's busy and 2026 it will become busier. So that's how much you will be able to do in an acute stroke patient. I won't get into this meta-analysis of EVT trials, and that's the whole thing. We are no longer stuck in this time window frames. So we definitely have the wherewithals to have a pathophysiological assessment and taken patients beyond the time window frames, and we are looking at a tissue or not just the time. Earlier it was time, recanalize, reperfuse the tissue. Now we have the tissue imaging. With this we determine the reperfusion recanalization irrespective of the time interval. And there's been lot of studies and a level 1 evidence whether it is IV or IA. Now just like heart attacks, you have a lot of wake up strokes. The guy wakes up and the family sees that he's not waking up, he's not talking, he's not moving one side. When did the stroke happen? Maybe it's 6 in the morning before the family woke up, or it's happened last night after dinner or somewhere during the night. So the wake up strokes always was stroke onset unknown. It's not that it's happened after dinner at 10 p.m. when the family saw him last. Unwitnessed strokes. And the patient can't tell you because either he is altered or he can't speak. So in such situations there has been a lot of studies and we've seen that even in wake up strokes you do this advanced imaging, you can pick up patients who can be salvaged. That's been there by IV. IA is intraarterial, is endovascular. And again the bottom line is look for mismatch, look at the artery and go and intervene. And this is true because of all these various trials, and this you'd find that when you do an endovascular thrombectomy, in such patients who gone beyond the time window frames. This is in fact 24 hours. You have this much of people till 13, all these guys are within MRS2, and that's what you need. MRS2 is walking with support. Okay, I need MRS0 and 1, that will be great, but at least you're getting them independent. With a walking stick you're able to do your stuff. Lot of people, when an elderly, when they come, don't they come and say, thoda apne aap bathroom chala jaye, apne aap kha le, isn't it? The family would need that kind of independence to be able to get on with their lives. All the time you won't have wherewithal having, round the clock nursing personnel to be able to take care of them, and that's possible. So whether there are large number of trials, I won't get into it, it will be just repetition of what I told you, and that's the stroke units. In fact, this is again no rocket science. It's not high-end infrastructure having this some kind of a starship equipment there. No, it doesn't. It just needs those personnel. Yes, cardiovascular monitoring, blood pressure. Again, I'm coming back to positioning. We lose more patients to aspiration pneumonia. They're fed the wrong way. They're fed when they're not supposed to be fed. They're fed in a wrong position and they die. So I think these are preventable things which are so small intervention done by just nursing personnel, and also giving the caregiver the right kind of education. Neuroprotection, I told you why we can't get this kind of a neuroprotection, why we don't have this magic bullet, because there's so much happening when there is an artery which is occluded. Your equations running tangentially, vertically, and all connected to each other. When there is ischemia, there is glutamate release, which is important at that point of time, but a few milliseconds later or a nanoseconds later it becomes detrimental. So in this cascade, that's the reason it's called it's like an avalanche. Unless I have a multi-pronged thing, something which is also able to take off excitotoxicity, it is a programmed cell death and take off everything, or there is one magic bullet. We haven't found that yet, so we are still searching for it. Okay, the holy grail continues. One thing which has really changed and advanced is the application with artificial intelligence. AI has changed this world in terms of stroke, whether it is in terms of detecting in triage, in able to, especially in the remote areas, it will tell you which is a salvageable tissue. Can I do IV thrombolysis, or do I quickly ship this patient in a hub and spoke model to a comprehensive stroke center and they will be able to do it? What is a stroke subtype? Is there a presence of atrial fibrillation which is actually contributing to this? Do I have to, my stroke prevention strategy needs to be changed? What's going to be the outcome? And the comprehensive rehab. In terms of apps and getting AI into the picture, we have AI aspects now. So this is great. But the only thing I'm a little worried about, and in fact I have an upcoming talk on artificial intelligence and neurosciences, which is also becoming sort of, it's not a news anymore, but I do have some reservations about AI. And there is natural intelligence, there is artificial intelligence, there is an acquired intelligence, there is something called a learning and using your brain. Unless you use your brain, you lose it. So bringing AI is great, but it should not, tell us not to use the brain. Because this is one thing, I don't know about other organs, but if you don't use your brain, you're going to lose it, and that's definitive. So AI is one thing which is coming in a big way in advancing, and it definitely has helped smoothen the wrinkles which are there in the stroke delivery system and also the stroke delivery pathways, irrespective of what tier you're looking at, primary, secondary or tertiary care centers in the country, because we have a 3-tier system of healthcare in the country. And so how do we improve this door to needle times? All these are there, pre-hospital notification, but that still is something which is existent in hub and spoke in private sectors, but not really existent in the government sector yet. And then you have all these things out there which is part of the Get With The Guidelines program, but the telestroke is the one which has changed it. The telestroke we actually launched in April 2000, so we launched it in April 2014 in Himachal. So Himachal, we took it because it's such a small little cute little state. There are 12 districts, 2 districts are out of bounds, Lahore and Spiti, you can't go there. The other 10 districts have a plain CT scan and largely a government sector driven thing. public, the private sectors are few players there. Largely it is public sector, and Himachal has one of the highest literacy populations after Kerala. I didn't know that. When we did this research, we've got that. So we started telestroke, and our model was a completely no cost WhatsApp model. So on a WhatsApp you transfer the image. We formulated this flying a plane checklist. Flying a plane, you have check boxes. The pilots have to check it. Even if one box is not checked, the plane is not going to go off the ground. So similar check boxes we put in that, okay, patient has come with whatever deficit, what is the BP, what is the blood sugar, transfer what is the sensorium, transfer this image, and we look at the image. And also they have a fair ground, that nothing white, nothing black. This is a crash course into stroke management. The stroke physician course is existent in the world. UK it is 2 years. We don't have a program like that in NMC. And when we weighed the cost and effectiveness, it was simply not happening. So we have to have these crash courses. So we said we took in all the emergency people who are managing emergency at a district level. Now they are managing a delivery, they are managing a trauma, they are managing a heart attack. So why not brain attack? So we got in this. Again, it had to be top down, again had to rope in the government, and then these CMOs were all trained and we launched it. So once we launched it, it took off. When we had this, the publication which went in, this was accepted even by the international thing. But now, I don't know what's happening with Himachal, I'm no longer involved in that. But in West Bengal, it took off and they trombolized 800 patients. They just published thing on a plain CT. District level, this is, mind you, free of cost to the person. I'm not looking at a private sector here. And it's very well being done in Tamil Nadu. They have the script model, which is a public-private partnership. So they've roped in, thing. And in Punjab with CMC Ludhiana, again a model with the Punjab government and this. So that's gone take off. But I do believe that in a private sector also there are a lot of hub and spokes existent in Gujarat and other places. Still, there are large sections in the country which have not. I've just been to Bhopal in last month. Sir, there is no EVT there, entire state. And IVT is also, that there are a lot of cardiologists, but unfortunately, so that there is an issue. So the core principles in ischemic stroke is all this. Yes, you know what is the parenchyma, the vessels, but time remains an essence, and this is there. Well, the same thing, right time and all that. Now, setting up a stroke protocol, I told you we need a team, is as good as this. It will turn chaos into order. And that because a role to play. And when you have these definitions, they're well grooved into that system, it will run. This is a very old classification. What is causing the stroke? Large, small, is it cardioembolic, is it other systemic diseases wherein all the others would come in? And there's something called cryptogenic, God knows why. We have a large section of stroke in young in the country. Less than 40 years is 25 to 30%, just like the MIs. There are various reasons, and one of the things which has now come up in prevention is pollution. It's number 4 risk factor for stroke and cardiovascular in the South Asia. India is South Asian country, whereas it is number 17 and 19 in Americas. So, that's the kind of, so for us, the pollution is especially particulate 2.5 matter has triggered strokes, it is well established, it's got level 1 evidence now. But in this cryptogenic, we also have now something called ESIS, which is embolic stroke of undetermined source. That earlier they said, okay, we do large artery, nothing there, cardiac, no vessel, no problem, no AF. So this becomes a non-lacunar, but it is some embolus somewhere. Now we brought in 3 major things. One is atrial cardiopathy. Second is D-dimer. You estimate a D-dimer, you're looking for a procoagulant situation which is related to malignancy. And the third is pro-BNP. So when you have a high pro-BNP, you're still looking at a cause where you're looking for a covert AF. That's where the device picked up AF. You have this ELRs, the extended loop recorders which can go on for a month also. Now what we have right now is a week. You can repeat it, get the covert AF and treat it. Because your stroke prevention there is beyond aspirin. It has to go beyond that. So that's been an advancement. And so on all the risk factors and in the preventive aspects, this is where we found that you have air pollution, South Asia, ambient air pollution in South Asia is number 3, it's not even number 4. BMI is number 4. One of course remains blood pressure, and of course diabetes. But number 3 is air matter pollution. Look at this, this is 12, 13. Globally is 4 and South Asia it is, East Asia is 2. I don't know which East Asia is which, where, I don't know, whatever. I am more interested here. So the pollution and the particulate matter has now definitely been important. And then everybody gets an aspirin, fine, but I think this is, maybe it's been given by Moses, but we have to go beyond that because there are a lot of questions here. Is aspirin the only thing which you can do? What about the combos? You have double antiplatelets, you have triple antiplatelets, you have a combo of anticoagulant and antiplatelet. What is the role and where do they come in to prevent a stroke? So earlier they had this, and this is an old one. They found there's something called SN risk score. So you may have a 65-year-old, he may be hypertensive, maybe diabetic and had a stroke. So what is the risk score? Maybe 3. But there may be somebody who is 75, is hypertensive, is diabetic, had a cardiac disease also, has a peripheral artery disease, continues to smoke like a chimney. What would be his risk? Definitely higher. In such a situation, they found that when you have a single antiplatelet, risk is high, your recurrence rate is very high. So it can again never be one glove fit all. So you have to individualize when a stroke patient comes in as to what is the regime which you can give to be able to prevent a recurrence from happening. Because the recurrence is really high in the first 3 months, definitely high in the first 48 hours, and mostly all goes off within the first 21 days. Mostly our cutoff is 21 days. So the newer guys on board are ticagrelor and silastazol. We don't use prasugrel and cangrelor. We use ticagrelor and silastazol now. And there are a lot of combos, whether it is aspirin, clopidogrel, which is favorite for cardiologists. We also have aspirin, silastazol, aspirin, ticagrelor, which is also really favorite of cardio. And we have aspirin and a low dose newer anticoagulant like apixaban, rivaroxaban and dabigatran. These 3 are available with us. So the indications have been for minor strokes, for intracranial atherosclerosis and for atrial fibrillation. And there are a lot of trials on this, a big evidence, and largely they found that whichever way you see in these kind of minor strokes, giving a combination the first 21 to 28 days helped, definitely. So when somebody is coming with a minor to moderate stroke, this is what we do. We definitely in a small vessel disease, minor stroke, we give double antiplatelets and we switch to single antiplatelet after 1 month. And there is evidence to say that. And then in symptomatic ICAT, that is intracranial atherosclerosis, we have a lot of trials, and we have an ongoing trial also now from AIIMS with the ICMR. We are giving this double antiplatelets when they have a large vessel stenosis inside the brain, M1 occlusion, M2 occlusion. In such situations, we are giving double antiplatelets for a year and seeing if that is better than just, but the international guideline is 3 months. And so for silastazol, we've got, this is a product of the Far East. It came from China and Japan. That's there in their guidelines. The West has not accepted it, but I think this has definitive value. So those patients who bleed with aspirin, you give 75, they'll bleed, especially when you have a chronic liver disease and other coagulopathies. Little bit of aspirin, they'll bleed. What do? Clopidogrel is even worse. In such situations, try silastazol. Actual dose is 200 BD, you can give half of the dose and see, because that bleeding risk is much less compared to the other antiplatelets. And so there are now recommendations which have come in 2019 that with a grade A recommendation. Well, I've already told you this, and when you also need a small amount of anticoagulant with an aspirin. This happens when you actually have a thrombus sitting there. Large artery, sometimes you will see the thrombus waving like this. It will say, hello, I'm here. And sometimes you can't take it out. Then in that situation, you have to put these things on for about a month. So that will give you time. Why? Because my stroke recurrence is highest in the first 1 month. That is where I hit really hard. After that I quickly de-escalate, because I give the same thing for a long period of time. What happens? There will be bleeding in the brain. It will offset my outcome. So this has been their aspirin with rivaroxaban. AF, it's a no-brainer now. You have atrial fibrillation, please anticoagulate. Just aspirin won't help unless you have a situation where you can't give it. There are a lot of scores. Just CHATSWAS has been there for a while. You will be able to know the risk of having a stroke if there is AF. But for a stroke person, it doesn't matter, because they're coming to us with a stroke, and that's enough to put them into an anticoagulation. And the VKA, there's 100 problems with our warfarin. And I think in India we have worse situations. It's not just diet interactions, and they have a therapeutic range which is so narrow. Less there'll be a stroke, which is thrombus, more they'll bleed. It's extremely difficult to keep that patient in the time to therapeutic range. But in India we have other issues. You don't even have enough accredited labs will give you an authentic PT-INR. They'll keep changing, isn't it? And you don't have it available in the boondocks of the country. A lot of villages and district hospitals don't even have it there. So that's the reason a lot of our cardiologists don't put them. Even in rheumatic heart disease, they never used to put them on warfarin, because they'll come back with bleed to you. But now things have changed, and we have a NOAC which is there, and all three of them, rivaroxaban, apixaban and dabigatran, are available, and they've also gone down in cost. That is the big reprieve. When it came with a big upfront cost. Now they are all easily affordable. Large amount of trials which have said that. But this is something which I tell my students, that in an AF, if you give an antiplatelet, you're reducing the stroke recurrence by 22%. From there down to 70-75% you can reduce the risk recurrence if you use the anticoagulation. And as compared to WAF, dabigatran, rivaroxaban, apixaban have an edge in terms of both safety and efficacy. And there is, after, say, when should I start anticoagulation? Should I after a stroke? When do I do early? When do I delay it? All these things are there as take-home messages. This would be practical importance to us, especially when a stroke patient comes to us. And the factors increase the risk. Supposing you have a large artery here. There are two things. One is an asymptomatic. They do coronary bypass, and they've done this also, and they found that this is also stenosed. There are a lot of caveats there, because it's the same artery, whether it's coronary, it's carotid, they're all the same vessels in the brain, in the body. So there is an asymptomatic where brain is still okay. There is symptomatic when there's been an issue. And sometimes when you do an MRI, there's a lot of silent ischemia, a lot of white matter changes happening. So there are factors which say that even if the stenosis is not high, sometimes there's ulceration, the plaque is irregular, absence of collateral fold. All of these factors are taken into consideration. Currently the evidence is in terms of doing the carotid angioplasty and stenting. The latest CREST-2 trial, which got published about 8 days back, which also says that as against carotid endarterectomy, you should do angioplasty stenting. The only trouble is angioplasty stenting, you are on double antiplatelets, endarterectomy or on a single antiplatelet. And rehab. Now the reason I put rehab is this is the really neglected part. Sab to kar liya hai, patient has disability, has a stroke, cognitive, can't speak and can't move, and then you tell them, okay, do physiotherapy. Physiotherapy is one, dumping ground. Go see the physiotherapist. It's gone beyond that. So we have dappled with stem cells. This is one of our patients who, this is from our Center of the Excellence of Stem Cells. This is from AIIMS. One of our patients where we had this mesenchymal stem cells which are expanded in the, the animal serum free media in the cell culture. And this is how the mesenchymal stem cells look after 28 days. This is the naive mononuclear stem cells. And one of the visually impactful thing, one patient who did well before and after functional imaging, which shows increased activity on the functional imaging, correlating with the clinical improvement. And also we've done diffusion tensor imaging, looked at the tracts, looked at the tractography, the longitudinal transverse, and we've been publishing since 2011 a lot of things. It's still a gray zone. There's no level 1 evidence that you have disability, go get stem cells. What stem cells, how to give, intravenous, intraarterial, what kind of stem is autologous, any other stem cells that you can give, how much, to which patient, how big should be the infarct, can I do it in hemorrhage? Still they are gray zones. Any one of you can answer one such question, you will get a Nobel Prize. The reason is it's still a holy grail. So it can never be that, the way some of the private sectors say, chalo hum stem cell de denge, and they give something underneath the skin. Some stem cells, it doesn't matter. It's actually criminal. So does it have a level 1 evidence and a grade A recommendation? No, it is still a research realm. And in physiotherapy regimes, we've done again a low cost methodology beyond just doing some हाथ पैर को movement कर दिया. No, it is beyond that. There is a science of how a rehab is done. And now there is level 1 evidence to do repetitive transcranial magnetic stimulation. This has got approved in 2024 in the International Stroke Conference in Phoenix. This was actually been published, and it's now that the US said yes, the whole world is practicing. But RTMS has always been there, and we've done a lot of studies from AIIMS along with IIT Delhi. So here the repetitive TMS has got a background in terms of improving spasticity, improving power, improving speech, and improving cognition. These are the main things and the main disabilities. We still don't know about visual field defects and other things which are also very important in terms of disability. But how much to give, both the hemispheres, what kind of frequency, where are you targeting, there are definitive protocols. But what I am seeing, sir, in Gurgaon especially in private sector, this is another new toy. So quickly these toys get commercialized, and that's what bothers me. So everybody's bought this TMS machine and they say, acha aap aa jana, and the regimes, apparently 5 minutes, and they charge you $5,000 and they're asking you to come every, I see patients coming there, हमने तो 30 sessions ले लिया, and I keep plucking my hair out and saying, what regimes, कहाँ से आए, what protocols are these? And these protocols are published, they are available to you. So the only thing is, it's a misuse of technology which sometimes, gets unfortunately they get a disrepute. So that really requires a soul searching. But RTMS is there now, well built into the physiotherapy thing, and we've published the data on that. Robotics is another one. You actually have robotics, and I think the country which has really gone way ahead was Israel, which I think out of just sheer necessity, they had this lot of young patients who lost limb and others, they had this robotics and the appliances to make them functionally mobile. But the robotics cost, there's the ergo robotic which actually can make somebody paralyzed walk, using that thing, costs 3 crores. So again, it's not something which can percolate down to, everywhere in the country. So we've gotten with IIT Delhi, we've developed this kinesthetic glove, and this is supposed to look like this at the end of it. This is a prototype 6, we haven't still got there yet. Aesthetically it looks terrible, but we're going there. And during this journey, all this electrical, biomedical engineering techniques, they are getting published. We have a very good team in biomedical engineering in IIT who's corroborating. And this is one of those exoskeletons we've developed for upper limb, for spasticity and the dexterity of the fingers, which is very important for a right hand. Especially, dexterity, you're able to sign, so not only can't sign on that, and so this again we've done. And then this is the apps which are being used, and this is across the country, lot of apps using virtual reality which actually program the brain as well. There's a hand-eye coordination. This is almost like, a wombat technique that the pilots have before they get into the, pilot training. So the hand-eye coordination, which is actually training the brain and getting the circuits back, and this is actually gaining a lot of ground. This is one of our machines we started using. The TMS is expensive, so we got transcranial direct stimulation method, which is a portable machine which can be used in district hospitals, and we got some data on it. Got all these things published. When you actually look into the guidelines, all of them are there. Whether they are, treatment workflows for India, the telemedicine thing, this we published in, I think, 2021, all these are there. But knowing is not enough, we need to do it. We need that attitude, the aptitude to do that. And not everything is based upon, altruism, I understand that. Just yesterday, we had a webinar with the Ministry of Health, and they've got some about 800 odd district level, the personnel, physicians up there to get again a crash course on the stroke. Dr. Jairaj Pandian was there. He's the president of World Stroke Organization, and we were the two resource people. So there again, you're giving them, yes, but the district person who's doing it should get an incentive when he does it. Whether it's monetary, whether it is something else, that one can decide. But it is human nature. When you say Sebash, you get that energy to go ahead. So I think you to understand the human behavior, and that's called noetic science. I found out this very recently. Sir, noetic science, I didn't know that such science existed. Noetic science is knowing, it's an inherent feeling. It's like, you look at a girl and you say, Dimag ki ghanti baji hai. This is the girl I want to get married. That is noetic science. How does it happen? That gut feeling. And there is a science behind it. They say that, its consciousness is universal, it is multitude. I am one. And this is across all religions, they teach this. When you say Om, they feel that there's a connect with the universal consciousness. So there is a science out there which is beyond what we practice as medicine, as hardcore, and it's not, everything is not chemicals and neurotransmitters and hanging in balance because of electrical charges. Beyond that. So that's where I think, your attitude, aptitude comes in. Primum non share, primarily do no harm. That's a Hippocratic oath. So that's holistic medicine, and these are the three, usually, for laughs of course, but then it really carries a message. This is the guy who's ordering everything. And they say, give me an aspirin too. That's not going to work, isn't it? And then, this is not the way of you say you walk the dog. When we say, you walk the dog every day in the morning, so he says yes. And everybody dies. Everybody, they say life is short, but journey is long. And there's a journey which actually defines who we are, isn't it? Thank you. Never ever give up on your stroke patient.